All right, great. So anyway, so we'll start over again. So 2019 LLSA, that I'm going to present all the articles for this. We're going to discuss the pertinent points of each article that are also test specific. However, we're not able to display the questions or the answers because of ABEM regulations. The purpose of doing it this way is that it allows us to record a version of the review for the LLSA that can be continuously accessed without having to be at a live webinar format. And so it allows for asynchronous time, so if somebody just wants to review quickly at home at any time, day or night, they can do this information, listen to this, and then get 100% on their LLSA and move on. And so we're going to discuss everything but the questions, and then from there. Is that cool?
Sounds good.
Cool. So the first article was published in Pediatrics, and it's a review of the Brief Resolved Unexplained Events, or BRUIs. These are guidelines with the intention to reduce costly and unnecessary medical interventions, to provide improved patient outcomes, to provide description of low-risk patients, and management advice for low-risk patients only. So the patient that presents with a BRUI who's a high-risk patient is not covered by these guidelines. And that's an important point to make. It's not intended to go through an explanation of the etiologies of this. It's really just a guideline of what do I do with a low-risk patient and how can I avoid a costly workup and still have the knowledge that I'm providing adequate, good outcomes for those low-risk patients. This subcommittee is a subcommittee on apparent life-threatening events, and that subcommittee wants to eliminate their title. They want to get rid of the term apparent life-threatening events and replace it now with brief, resolved, unexplained events instead. And so that way they can help differentiate one patient group from another, because the ALTI group wasn't that well differentiated, so they were still getting very costly workups and were being admitted to hospital often and so on and so forth. And so they decided, let's change the name of this and let's define some new guidelines. So a BRUI is defined as having one or more of the following in an infant, so somebody less than 12 months of age, either having pallor or cyanosis, or having an abnormal or absent breathing, having abnormal tone, or altered responsiveness. So you just need to have one of those in an infant for us to term that as a brief, resolved, unexplained event, as long as whatever the event that's causing the pallor has resolved, and same thing with the breathing and tone and responsiveness. The low-risk patients are defined as a group that have those symptoms for a duration of less than a minute, who are at least 60 days old. So we're really dealing with a group that's between 2 months of age and 12 months of age, where this applies. This is an initial event only. In other words, they've not had a similar or concerning event like this in the past. And the patient did not require any CPR by any trained providers. So if the family performs CPR, it doesn't count, but if a medic shows up on the scene and performs CPR briefly, those patients are BRUIs. Those patients are in a high-risk group already, and so you don't treat them that way. And then there's got to be an absence of concerning physical findings or historic findings that would still allow you to consider this person to be low risk. And then in the patients that are preemies, they need to be at least more than a 32-week ex-preemie, and they need to be past 45 weeks of corrected gestational age. So that puts an ex-preemie more or less in the past 2-month point, as opposed to the normal term 2-month-old and under for infants. Their algorithm is to perform an initial medical assessment after the event was observed in a child under 1 year of age. If the patient is well appearing, then you clinically characterize the event as a sudden, brief, and now resolved episode of either cyanosis, absent, decreased, or irregular breathing, marked change in tone, so they can be hypertonic or hypotonic, or altered responsiveness. And if that criteria is present, you can perform an appropriate history, physical examination. If there's no explanation for that event, diagnosis of brief resolved unexplained event is made. Now, going back to the first branch point, if the patient's is not well appearing, has additional symptoms that are going on, with cough, respiratory difficulties, fever, then that's not a BRUI. And so work that up like you would normally, and don't consider this to be a low-risk group. Now, going back to the BRUI group, so there's no concerns based on history of physical examination. You apply the risk stratification that they're over 60 days of age, they're over 32 weeks if they were a preemie, they were at least over 32 weeks gestation for preemies and more than 45 weeks old now. No CPR, and this is the first event, then that's a group that's listed as a low-risk group. If there's any concerns from the physical exam of risk of sudden death, of some form of feeding or respiratory problems or anything else like that, then that's a higher risk patient. So their management recommendations are as follows for the low-risk patients. And they break this up into what you should do, what you may do, what you should not do, and what you don't need to do. So what they say you should do is you should educate the parents and caregivers about what a brief resolved unexplained event is, and engage them in decision-making to guide evaluation, the disposition, and follow-up, and to offer resources for all of these patients for CPR training for the caregivers. So that's the main thrust of the recommendation from this committee is if you have a kid that comes in with a BRUI that looks well now, but had a brief event of pallor or was hypotonic and looked like they had respiratory problems, that at the very least, all of them should leave the hospital with resources for CPR training and how to manage an infant. What they also say that you could do and may consider is obtaining pertussis testing, as well as getting a 12-lead ECG, briefly monitoring those patients with continuous pulse oximetry and some serial observations. The duration of the observations isn't really specified by the group, but I think it would fall into what the typical length of stay is in an emergency department, so you're probably going to watch a kid for an hour or two at least before you just discharge. So this isn't going to be a triage, front care, discharge out the door. It'll be, let's bring them in, watch them for a couple hours, make sure there's no other events, and then kind of go from there. What you don't need, what is a should not do is in these patients, you should not obtain a white blood cell count, blood culture, CSF analysis, culture, serum sodium, potassium, basically chemistries, and do a full altered mental status workup on them. They should not get chest x-rays and echocardiograms, EEGs, studies for GERD, or other laboratory evaluations for anemia. Shouldn't initiate home cardiorespiratory monitoring. That's probably the most important aspect of those in terms of being able to convey to the parents that committees studied this, and this is not a group that needs home apnea monitoring, and that these are not patients that should be prescribed acid suppression therapy or anti-epileptic medications. And then what you don't need to do as well is attain viral respiratory studies, so you don't need to do an RSV on these kids, an influenza, urinalysis, glucose, so on and so forth, or neuroimaging, or admit the patient to the hospital solely for cardiorespiratory monitoring. So that's overall kind of the thrust of what this committee came up with, is like, listen, they're low risk, they don't require an extensive workup. If you feel that this is an event that could be related to pertussis, fine, go ahead and screen for pertussis. Okay to screen with a 12-lead EKG, and then just monitoring vital signs, including pulse oximetry, but otherwise no need to delve into a more extensive workup and evaluation for that low-risk group. So on the test, question 1 addresses this article. The next article is on executive leadership and physician well-being, looking at 9 organizational strategies to promote engagement and reduce burnout. This is a article that's really written from an administrative standpoint. It does acknowledge a number of issues that have to deal with provider burnout, and recognizing that provider burnout is not just the responsibility of the provider themselves, that their own reason for burnout has systemic etiologies to them, that the environment that we work in, that the culture that we practice in, that the rewards and incentives that exist in our work life, as well as the amount of flexibility that's there, all contribute to how providers burn out. And that there is an administrative responsibility to address that as well, rather than saying, well, that person burned out because they've got poor coping mechanisms or something else is happening, right? It's not putting all the responsibility on the provider, at the same time recognizing opportunities to improve that. So here's a very complex matrix that's there, and we're not going to go through every single one of those boxes, thankfully, but it gives you an idea of what the breakup is to investigate provider burnout. And the nice thing about this is it does provide a lot of opportunity. So I think that when you look at this, if you're in any part of your career where you're having burnout symptoms, and burnout is a natural consequence of the type of work we do. That doesn't mean that it's a terminal event for our work life to describe it as burnout. It's just there's a series of symptoms that we have where we have some compassion fatigue, physical and mental fatigue, as well as losing some of the usual sense of wellness that we have when we practice. That leaving a shift and feeling good about what you did that day sometimes wears down, especially if you're working a bunch of shifts in a row. And so the provider burnout may not always be related to the number of years you've been in practice. It could just be related to the number of shifts that you've done in a row as well. And this is something that at least when I'm scheduling the residents, I go through an effort to try to never have them have too many shifts in a row, so that I'm not allowing that to occur to them during their training. And you can see in our own schedules, for the most part, most of us are protected from having more than 4 shifts in a row to protect us as well. And so these individual factors look at where our practice location is, what our experience is like, what our self-awareness is in terms of the meaningfulness of the work that we're doing, our own personal values with regards to culture, and well as looking at personality and assertiveness and other traits kind of help you maintain coping through this. But then when you look at this out of the individual factors and start looking at the other factors, you realize, well, here's a much broader series of events that contribute to that sense of wellness. And so the work unit factors have to do with, well, what are your productivity expectations? What's your team structure like? And is there, and what things are done at work to provide help for efficiency? With regards to efficiency and resources, is there available support for the staff and their experience? In other words, if your staff is being stressed out, that's certainly going to make your day stressed out as well, and you're going to share that, since we're especially in the team environments that we all practice in. So a stress on one team member is certainly a stress on the other, and so those interactions and what our nurses and techs and everyone else are feeling affects our whole group. And then, in addition, looking at the culture and values of the work unit leaders, how well do the administrators help support a environment of teamwork and productivity and working together, as well as looking at the degree of flexibility and control of physician calendars, looking at the collegiality and practice environment, and as well as looking at the work integration of life, such as what's the call schedule like, how much cross coverage do we have, and are there issues with coverage? And then the organizational factors at the hospital level are also looking at, well, what are the metrics that the hospitals are using, and are those metrics in any way also contributing to burnout, and how can we adopt metrics that balance both meeting the goals of the hospital's needs on both a patient throughput basis, but as well as on the quality of care basis, and avoiding sentinel events without creating an undue burden on on the staff and on the physicians that practice in that group. And then looking at what are the organizational culture of that hospital, the practice environments and opportunities that they provide for professional development, and then looking at what the overall culture and values are from a mission standpoint, and the service and quality versus profit balance that's addressed at each hospital. And then you can see there's national factors that influence these as well, which have to do with how Medicare and Medicaid reimburse the financial impacts on hospitals. And you can see there's a trickle-down effect or a waterfall effect that occurs to everybody based on national factors as well. And this matrix basically helps you kind of go through and identify areas that if you have certain strengths that you can build upon, that's great. If you can see that there's certain blind spots that you have that you need to work on, it also gives you an opportunity to look at, well, what can we do there? And it goes from an advocacy from a personal standpoint to a work unit standpoint within your department to an organizational standpoint from what can the hospital do to what can you also do to advocate on national events and national factors that further contribute to it. So when I first started reading this article and was realizing how much of an administrative perspective it had, the authors went out of their way to de-emphasize the individual factors, and it seemed to not address how an individual provider might feel. But when you look at the broader scheme of what they're really trying to get at is trying to understand and study an event from a multidisciplinary standpoint rather than a single perspective. And so we've pretty much covered all that, and this is what question 2 on the LLSA covers. Third article is on management of an unexpected delivery in the emergency department by Dr. Gupta. The first 3 questions that are important when having a kid, having somebody who's about to deliver a kid, is this a term gestation? Does the kid have good tone? And is there breathing or crying? So those are the first 3 things to think about to kind of calm your mind as that kid's coming out. Is it term? Is there good tone? Is there breathing or crying that's occurring? This is a list of recommended equipment to have for neonatal resuscitations, having a radiant warmer, warm blankets, a cap for the kid, plastic wrap. I'll show you a picture here in a moment of what the reason why they want plastic wrap. Thermal mattress, bulb suction, neonatal face mask, having endotracheal tubes that are at least as sized from 2.5 to 4.0, with or without stylets, and then laryngoscope blades from 0.001 and 1 Miller, bag valve masks that are appropriately sized, and then the LMAs for size 1 neonatal, and then cardiac leads, monitor, CO2 detector, tape, and so on and so forth. The algorithm starts off where you'd like there to be antenatal counseling, team briefing, and equipment check, and then birth occurs. And if there's a term gestation, good tone, and breathing, then great. Infant stays with mom, routine care, basically keep the kid warm, maintain normal temperature, position, airway, clear secretions if needed, and ongoing evaluation. So kid shows up, mom shows up, she gets put in her room, baby's coming out. Again, this is a term gestation, kid looks good with good tone, breathing and or crying, baby can stay with mom. If, on the other hand, those features are not present, then we need to start making active measures to warm and maintain temperature, position, and airway. If there's any gasping, so any abnormal labored breathing or apnea, or if the heart rate is below 100 beats per minute, then positive pressure ventilation is stressed. So this is a point where we need to begin providing some form of positive pressure ventilation, bagging, checking the SpO2 monitor, and getting the kid on an ECG monitor. If there's the kid, again, that didn't have good tone but is breathing fine and heart rate is over 100 beats per minute, then if there's just labored breathing, and or persistent cyanosis, then again, position the airway, put them on an O2 monitor, supplemental O2, and consider some CPAP or positive pressure for that patient. Now, if we go back to the patient that was having obvious respiratory difficulty or was bradycardic, if the heart rate, despite positive pressure ventilation, is below 100 beats per minute, so they're not perking up and their heart rate's not coming up, then this is when you really need to assess the chest movements, and you're assessing to see, does this kid, now that you've started positive pressure ventilation, one thing is, was it vigorous bagging, and did you just cause a pneumothorax? So you really need to check the chest movement and carefully listen on either side. If you ever do a PALS, sorry, not a PALS course, but if you do the neonatal resuscitation course, the treatment for a pneumothorax in this group is just taking a 20 gauge IV catheter and putting it in the fifth intercostal space. So that's your chest tube in a neonate. So again, patient's heart rate's not coming up despite positive pressure ventilation, and this is where you need to start considering endotracheal intubation or LMA. If the heart rate is below 60 beats per minute, that kid needs to be intubated already, if not done. Start chest compressions, coordinate with transitioning with your positive pressure ventilation, 100% FiO2 on ECG monitor, and consider putting in a umbilical vein catheter at that point. And if despite being intubated, chest compressions going, the heart rate still staying low, this is when IV epinephrine is being given and giving fluids to treat for hypovolemia, and kind of going from there. So in general, when a kid's born, their initial SpO2 is not, especially if they've shown some signs of cyanosis at birth, isn't expected to come straight up to 100% right away. So the targeted predicted SpO2 after birth is in the first minute 60 to 65%, in the second minute up to 70%, in the third minute up to 75%, in the fourth minute up to 80%. So at the fifth minute, you're really expecting kids to be an SpO2 of 80% or higher. And so that shouldn't give you great alarm at the fifth minute if they're at 85%. Like that's okay. That's a predicted SpO2. You don't need to be aggressive with that patient. But if it's fifth minute and they're in the 70s, something's up, and you need to be aggressive at that point. The major update that they stress is that the chest compressions are done as a two-thumb technique for compressions in the mid-chest. So hands wrapped around the chest wall, your thumbs are the compressors on a neonate. And so that's one of the things to really focus on. One of the other updates is that it's no longer recommended to immediately provide tracheal suction in a non-vigorous newborn with meconium-stained amniotic fluid. That was one of the things I did a course when I was learning how to become a simulation instructor. It was up at Stanford, and the Stanford course was taught by the neonatal resuscitation group. And the guy that runs that is this like incredible simulation guy who's actually one of the directors for simulation for NASA. So you're getting this really cool experience from this guy that trains all the astronauts and helps them develop these really good skills of self-assessment and simulations and so on and so forth. And when you're in emergency medicine, you don't get trained in neonatal resuscitation. It's just not. It's the one little area that you get a little bit of experience with it if you have cases like that during your OB rotations, but otherwise there's not a specific neonatal ICU rotation that you do because there aren't many NICUs, there's NICUs everywhere, but nobody does rotations in them, or rarely. So I'm on that course, and we get a meconium-stained kid, and this is back when you would do this instead, and you intubate the kid, and then you use the endotracheal tube as a suction, and you suck through the endotracheal tube, and you pull the whole endotracheal tube out, and then you go back in and do it a couple more times. And the initial emotional response of pulling an ET tube out was so odd to me that I thought, well, this is, it felt extremely foreign and uncomfortable. Like, I only put these in. These only go in one way. They're not supposed to back out, even though I know every anesthesiologist backs them out after every case and so on and so forth. And I'm sure, Ian, if your experience, I don't know if that was a difference for you when you were in ICU, that when you were extubating patients, because in the ER, all of us still feel awkward when we extubate somebody. And was that something that you had to learn to feel differently about, or?
Yeah, absolutely. I think there's a lot more fear going through your mind when you're pulling the tube out. The nice thing about the ICU is you're there, and just like the ER, you can watch them. But yeah, it started off as a very foreign thing, taking people off ventilators.
Yeah. So, and that's, in a neonate that's got the stained fluid, it was just odd to be like, wait a second, I just got the airway, and now you want me to suck this and pull this out. So anyway, their major update, it's no longer recommended to have to do tracheal suction, just because it's meconium stained fluid. If they're having severe respiratory distress and their heart rate's low and all this stuff, well, then you're just intubating them and you're going to treat them from there. When you're administering positive pressure ventilation, it's really critical to assess the heart rate, the spontaneous respiratory efforts, the effectiveness of the assisted breaths, and getting an idea of the pre-ductal oxygen saturations, which means looking at the right arm for that. If you're performing, the other recommendations are that in the compression ventilation ratio in a neonate, it's different than in kids. So in the newborn, the compression ventilation ratio is 3-to-1. So it's not 15-to-2. It's not continuous chest compressions without ventilation. It's a 3-to-1 ratio compression to ventilation. Another issue that they emphasize is that we need to be performing more delayed cord clamping. So on the basis of the data that they looked at from systematic review, they realized that delayed umbilical cording is defined as clamping the umbilical cord from 30 to 60 seconds after birth. So it's not a prolonged delay. It's just, okay, kid's out, you've got the cord, put them down in a dependent position from the cord and wait 30 seconds before you cut the cord, or wait up to 60 seconds if need be. That delayed clamping has been associated with less intraventricular hemorrhage, higher blood pressure, higher blood volumes in kids, decreased need for postnatal transfusions, lower incidence of necrotizing enterocolitis, and then furthermore, the delayed clamping has not been shown to decrease mortality or incidence of severe IVH. So those kids that are having issues that are causing severe intraventricular hemorrhage, the delayed clamping isn't necessarily going to decrease mortality in somebody who already has a very severe event occurring. But the only adverse consequence of delayed clamping was found was a slight increased issue of bilirubin. So you have a slight increase in the kids requiring phototherapy. The picture on the right shows a premature neonate wrapped in plastic wrap immediately after delivery to optimize the thermoregulation. So if you don't have a warmer ready right away, then wrap the kid like they're leftovers. and keep them warm. Just don't put it over their face, right? So a little saran wrap around the chest and body, and here's your little present. All right, Table 2 kind of looked at time-sensitive events for looking at labs to verify and to further evaluate kids that are coming out if they're not looking right. HIV testing is important, Hep B, syphilis testing, as well as maternal blood type and antibody testing. So those that are Rh negative, it's important to obtain blood type and Coombs on the cord blood of the infant. If their blood type's O, obtain blood type and Coombs on cord blood, and especially if it's unknown, get mother's blood type and antibody testing as well. And so this is just here as a reference, and these slides will be available as well. So a lot of these slides are kind of busy, and they have specific table information from the articles, when I think that there's something that you might gain from looking at on your own. So question 3, refers to that article, as does question 4 and question 5. So it's three questions to that article that we covered. The next article is on treatments for hyperemesis gravidarum, nausea and vomiting in pregnancy. This is a systematic review by Dr. McParland and others. Here they looked at a number of different therapies based on the symptoms. So if the symptoms are mild, moderate, or severe, here are the therapeutic recommendations. The mild symptoms that are often managed at home include ginger supplements, pyridoxine or vitamin B6 supplements, or antihistamines. So if there's an issue of nausea and mild symptoms of vomiting that are occurring at home, but not so much that it's causing signs and symptoms of dehydration, then recommending giving ginger is the most common regimen, 250 milligrams every 6 hours, giving 10 to 25 milligrams of B6 every 8 hours. The adverse effects of ginger is it causes acid reflux. The adverse effects with B6 is that there can be drowsiness, decreased sensation to touch, and temperature and vibration, and basically can affect your posterior cord in high doses. And then with antihistamines, again, you get drowsiness, dizziness, muscle twitches, and it's contraindicated in anybody that has glaucoma or has high blood pressure or epilepsy. So in those with moderate symptoms, so we're having signs of dehydration, recommendations are to give Reglan. Reglan's probably the safest. Let me take that back. Reglan is a safe drug in this group. I won't say it's the safest. It's the safest drug to give to a pregnant migraine patient. And we'll come back to that later in another article. But Zofran's very safe, 4 milligrams, as is promethazine. And then the combination of doxalamine and pyridoxine. And I'm forgetting the trade name for that right now, but I'm happy to forget it.
Diclegis.
I'm sorry? Diclegis, that's right. Thanks,
Diclegis.
Sean. Yes. So, and just briefly, there's an interesting history to Diclegis and Zofran. At one point, when Diclegis was combined together, like over 10 years ago, and the company that was selling it got ambushed by another company that said that it was associated with birth defects. And the cost to litigate and go through all of this was higher than what their revenue was going to be, or their projected revenue. So that company basically just went out of business. And there was a similar effect that had occurred with Zofran at one point too. So what was interesting is when Diclegis came out, there was initial reports that Zofran was associated with birth defects, and Diclegis got a foothold in the market again, based on what took them out of the market from before. It was kind of an interesting little back and forth that happened with it. Neither of them are associated with birth defects, really, but it just goes to show you kind of what occurs sometimes in the pharmacoepidemiology and how new drugs get introduced and marketing issues that are used to address that. Anyway, so moderate symptoms, Diclegis is safe. The adverse effects are drowsiness, dizziness, and patients can get some stomach pains and even diarrhea with it. It's contraindicated if they're on a monoamine oxidase inhibitor, which is just such a rare event for somebody to be on these days. Reglan, 10 milligrams every 8 hours. Again, you can get a dystonic event from this. Usually dystonic events that are associated with Reglan are on repetitive uses, not on single use. And it's contraindicated in kidney or liver disease, patients with CHF or seizure disorders. Promethazine, also with dizziness and similar issues to Reglan. That can be somewhat mitigated by giving the akathisia that occurs with promethazine can also occur with Reglan. In patients who are on compazine, you can add Benadryl or an antihistamine to that, and that mitigates the akathisia for compazine, but it's not a recommendation to do that for Reglan. And then Zofran can be associated with anxiety, dizziness, constipation, dry mouth, irritability, and the contraindication is patients with prolonged QT as well as in patients who are hypomagnesemia or on any medications that could also prolong the QT interval. And then when we get to severe symptoms, it's Zofran 48 milligrams every 8 hours and consideration of corticosteroids with hydrocortisone. The risks there being increased risk of infection, gestational diabetes, and then should be avoided in patients with systemic infections unless there's specific anti-infective therapy that's being used at the same time, and avoiding in patients who've received live virus immunization or have a hypersensitivity to any component. IV fluids are obviously important to give compared to different compositions of fluids. The intervention groups received IV dextrose saline with antiemetics, and the comparator group received normal saline with antiemetics, and repeat measures analysis demonstrated that in the IV, basically the D5 normal group, there wasn't any reported difference with vomiting, but in summary, they felt that there was limited evidence to indicate that D5 normal saline may be associated with better improvements than normal saline in the moderate to severe cases. So this was a recommendation that would be worthwhile just to know that this group felt, well, D5 normal saline is a better fluid with antiemetics to give to this group as opposed to just normal saline with antiemetics. And that was a level B recommendation as opposed to a level A recommendation that has a high degree of support for it. Any questions about that?
Nope.
Okay, so again, D5 normal, greater improvements in their symptomatology without any difference in vomiting, but they felt better with D5 compared to normal.
Good, I'll give them sugar.
There you go. So question 6 and 7 refer to that article. If you and you may notice that there's certain things that are being highlighted and emphasized here. Those are probably very test-specific items to give consideration to. So the next article is on fire-related inhalational injury. This is by Dr. Sheridan, and is an interesting article that goes through, how do you characterize the inhalational injury and determine what the appropriate treatment should be? If you just see some soot in the nose, does that mean that you need to intubate every patient that has soot in the nose or soot in the mouth? And the answer to that is going to be no. But there are specific things that you do need to be concerned with and how to manage these patients. So for them, the presence of inhalation injury doesn't mandate intubation. If the airway is patent, if it's not threatened, particularly if the cutaneous burns are less than 20% of body surface area, and we're not talking about 20% of the body surface area, the face and head and chest, but the other or the portions of your trunk and extremities. If you can keep the head of the bed elevated, provide humidified air, and close observation are all appropriate in patients that have a lower risk sort of presentation. Endotracheal intubation is advised in patients who have facial edema, to present with any degree of hoarseness or stridor, in patients with large cutaneous burns in whom facial edema is likely to develop with resuscitation. In those groups, it's crucial to be aggressive with intubation. Their algorithm here for early management is to look at, and you start here on the right, if there's inhalational injury suspected, take a history, perform an examination, perform diagnostic testing. If in that evaluation nothing else is there, then it's just usual burn care, attending to the wounds, keeping them cool, and providing adequate antibiotic, well, not necessarily antibiotic, but providing adequate topical support. There's actually been a de-emphasis in burn care lately of placing topical antibiotics as much, although the burn center locally here likes to place zero-form dressings on the wounds as a measure. If the patient, again, has a suspected inhalational injury based on the history and exam and findings, then the next thing is to determine whether the airway patency is threatened, check for presence of hoarseness, stridor, facial edema, and if there's any labored breathing or impaired oxygenation. If so, then intubate those patients. provide lung protection ventilation strategies, perform pulmonary clearances, and so aggressive pulmonary toilet is necessary in treating infections and complications and being prepared for that. If those features are absent, then observe the patient, keep the head elevated, provide humidified supplemental therapy, perform chest physiotherapy, monitor oxygenation saturation, and examine the patient every 2 hours. If they remain stable, then you're in that loop. If they're not stable, then intubate them and go down. And then you consider extubation when the airway is patent, and ensure that there's good compliance and gas exchange, and ensuring that there's initial major surgery has already been completed. And so those are going to be really more in Dr. Butler's realm rather than our realm, but that's a recommendation based on this article. Important exposures to be concerned with is one, cyanide exposure. Hydrogen cyanide is released in the combustion of a number of synthetic polymers. So a number of different types of plastics contain cyanide in them inside vehicles. That's a known issue. But it can also be so in if you're at your grandmother's house and she's got a lot of souvenirs around, that house is going to have a lot of synthetic polymers and such, or in a kid's room or something else like that. Anyway, this is a similar issue with carboxyhemoglobin. Hydrogen cyanide interferes with oxygenation utilization, and it's thought to be a minor contributor, along with anoxia, to carbon monoxide poisoning and to early deaths from acute inhalational injury. The key feature in the cyanide poisoning patient is that they have a persistent acidosis despite an otherwise successful resuscitation. So if you've intubated this patient and their oxygen levels have come up, and their PaCO2s are in like the 30s and 40s, so they're adequately ventilated, they're adequately oxygenated, but their pH is 6 point something or 7 or 7.1 or 7.0, whatever. That's a sign of cyanide poisoning. So your ABG will inform you that the patient's got cyanide poisoning if you're seeing a persistent acidosis despite meeting the otherwise resuscitation metrics. Then going over to carbon monoxide exposure, this is a clear, colorless, odorless gas. It binds actively and strongly to the hemoades and makes it difficult to offload O2. The carboxyhemoglobin levels rise to 10 to 20%. Those are generally just associated with headache and nausea. When they're 20 to 30%, you start getting muscle weakness and impaired cognition. And when the levels get 30 to 50% or higher, now you're dealing with cardiac ischemia, unconsciousness, and the higher levels are often lethal. Treatments with oxygen during pre-hospital care, that can sometimes obscure the degree of initial exposure because carboxyhemoglobin normally will normalize quickly when the patient's breathing 100% O2, so that's one of the treatments for that. And the cytochrome clearance takes a little bit longer for that to occur, so there can be delayed development of neurologic sequelae after the exposure. And so it's just something to be aware of, that the O2 may improve, but there still may be a neurologic consequence that's somewhat delayed. Question 8 and question 9 refer to that previous article. The next article covers managing initial mechanical ventilation in the emergency department. And so this is by Dr. Weingart, who's really well known in education for emergency medicine and critical care especially. He really simplifies this for all of us into basically 2 strategies. And one of them is really emphasized more than the other, but because of the frequency of use. But basically, there's a lung protective strategy and there's an obstructive strategy. So those are the 2 strategies. The lung protective strategy is the one that we're going to focus a little bit more on because it's used more often. This is basically focusing on using low tidal volume ventilation to reduce ventilator-associated lung injuries such as barotrauma and volutrauma that occurs. So one of the biggest risk factors for secondary injury to the lung and the intubated patient is that we're using too much volume, and that it's appropriate for patients already demonstrating signs of acute lung injury to also be used for intubated patients to prevent disease progression in that. So this is why we want to use this strategy. The strategy is chosen for patients that are intubated in the emergency department who don't have obstructive disease. So this is not for the asthmatic COPD patient that's crashing. That's the other strategy that we're going to get to. The lung protective strategy is based on the ARDS-NET data, the ARMA data, and has looked at one of the few ventilator trials to demonstrate mortality benefit. So following these guidelines has demonstrated to lessen mortality. And so we'll get to those in a moment. But despite those benefits, a lot of the ED patients are still not being managed with a protective lung strategy. So we'll get into what that is. The obstructive strategy is meant for the crashing asthmatic COPD patient. And that's basically outlining how do we manage the pressures and trapping and barotrauma that occurs in that specific group. So in the lung protective strategy, the recommendations here are to start at 8 cc's per kilo for your tidal volumes. And that's the goal in both strategies. So in both those, in either strategy, you're starting off at 8 cc's per kilo. In the lung protective strategy, inspiratory flow rate is started at 60 liters per minute and is adjusted for comfort. So we're not adjusting the tidal volume for comfort. We're going to adjust the flow rates for comfort and starting at least 60 liters per minute. Higher flow rates can give you a sense of a higher amount of air that's being delivered to you. So if you feel like you're trying to breathe through a straw and can imagine a degree of anxiety during the initial inspiratory portion of your event, so you're trying to pull through the straw and you're wondering, am I going to get enough air? Is it coming in quickly enough? That's really your inspiratory flow rate. You can kind of think of it that way. And if you increase that rate, you have a general sense that you're getting a rush of air faster, so your comfort level may be higher in that setting. So seeing somebody who looks like they're uncomfortable on the with this, adjust the flow rate first before you consider doing anything else. The respiratory rate itself is used to adjust for PaCO2. For older guys like me, who, when I was introduced to a surgical ICU, we would play around with the tidal volumes and the respiratory rate to get to a predicted PaCO2 to try to do that. And that was probably a bad lesson for us to learn. This dumbs it down a little bit and just says, listen, just focus on the respiratory rate. Maintain the tidal volume so that you're not increasing the risk of volume trauma, and just change the frequency of the breath to adjust the PaCO2. Starting off at a PEEP of 5 for lung protective strategy and adjusting according to a table. I'll show you that table in a moment. And starting FiO2 at 40% and making adjustments to that table based on the table that they're going to show us below. And then for safety issues, measuring the plateau pressure is really important, and measuring the plateau pressure initially, and then at least measuring those pressures every 20 to 30 minutes afterwards is the best safety approach to protecting the lung from getting barotrauma or some other secondary injuries. If you're seeing plateau pressures that are greater than 30 centimeters of water, decrease that's when you begin to adjust tidal volume to begin decreasing the tidal volume. Otherwise you're locked in. So the recommendation is to start at 40% and then make adjustments. And the adjustments here are that you'll notice here, if we're starting at 40% and a PEEP of 5, the initial adjustment is to increase the PEEP to 8 and maintain the FiO2. And then maintain that PEEP and adjust the FiO2 to 50%. And then increase the PEEP to 10, maintain that, adjust to 60%, and kind of walk your way up. And the rationale behind this was that patients were being hyperoxygenated too quickly when the issue was that you were trying to recruit more alveoli. And the recruitment of alveoli was more important than what your fractional inspired oxygen was. And so that's what this table basically takes you to, and basically says, if you're at 100%, then your PEEP's at 20, and that's your strategy of going up like that. And so these are in patients who are presenting where it looks feasible that you're going to be able to start off with an FiO2 of 40%. I think there's some rationale to give consideration to where you have a patient that is in severe pulmonary edema, you've seen the chest X-ray, you've seen that, and then 40% is probably unlikely. This table is still helpful in giving you an idea of what your ratio of your FiO2 and PEEP should be in those patients. So I think that those are reasonable places to give consideration to. I wouldn't follow it necessarily as dogma, but I think I would look at this as a way of refining the way that we manage a patient, and gives us a nice, thoughtful strategy in patients that maybe are requiring higher PEEP and higher FiO2 than just the 40%. Is that a fair way of putting it, Ian?
Yeah, I think so. A lot of times ventilator management ends up being really dynamic as you look at the patient and spend a couple minutes with them. But in terms of just kind of initial settings, this makes a lot of sense.
Okay, cool. And then in the obstructive group, so this is the COPD asthma crashing patients, 8 cc's per kilo. You're going to start at least at either 60 to 80 liters per minute for inspiratory flow rate. And then instead of adjusting, at least for us in the ED, instead of us adjusting the I to E ratio, we're essentially adjusting that ratio by decreasing the respiratory rate to start off with. So we're starting off with the respiratory rate of 10 breaths per minute. So the frequency in essence, you're giving them a longer expiratory time by decreasing the frequency of respirations. And basically adjusting that rate to allow for full expiration. This is a 0 PEEP group to start off with. And there's some people that, some resuscitationists talk about starting off with a little bit of PEEP, but less than 5 centimeters. And then starting again at 40% FiO2 and adjusting for a goal of an SpO2 greater than 88%. Still, from a safety standpoint, measuring plateau pressures is very important with the same time frame that we mentioned before. And if the plateau pressures are greater than 30 centimeters water, or the flow time graph doesn't show shows incomplete expiration, then you need to decrease the respiratory rate even further. So question 10 and question 11 and question 12 all refer to that article. Next article is on mesenteric ischemia. This is by Dr. Clare and Beach. This is a good review article. Basically breaks up mesenteric ischemia into 3 subtypes to give consideration to. One is acute arterial, the second is chronic arterial, and the third is venous thrombosis. The acute arterial, of these, 80% of these are due to an acute thrombus formation. In the chronic arterial, it's really a progressive atherosclerotic disease. And then in the venous side of mesenteric ischemia, it represents about 10 to 15% of cases. This is usually due to venous thrombus that's contributing to that. These patients present with abdominal pain. They often have pain out of proportion to exam, and their pain is frequently rapid and progressive. The imaging workup for this is stressed to use computed tomography. It has 95 to 100% accuracy, and has really become the recommended method for imaging for diagnosis, looking for the ischemic syndromes. It allows for the images and the origins and the length of the vessels to be rapidly reviewed and characterize the extent of stenosis or occlusion, and the relationship to the branch vessels also aids in the assessment of options for revascularization. The authors also stress that you could use ultrasonography, and that ultrasonography is sensitive and specific, so you've got a specificity of 85 to 90% based on ultrasound. It's a low-cost tool and allows for quick bedside assessments. I spent a week recently on a little island, and we had an ultrasound there, so that was my only tool. So if I had a patient with that, ultrasound would be the only way I could use to do this. And with 85 to 90% specificity, it's helpful to know that. But obviously, it's operator dependent, and the biggest drawback to ultrasound is if the patient has any significant distension, then the amount of bowel gas that's present obscures the ability to effectively evaluate the vessels. MRI and MRA is an attractive option in patients, particularly if they've got kidney disease, and particularly in patients that you are probably more suspicious of having chronic mesenteric ischemia. But obviously it takes longer to perform. And then catheter angiography was previously considered the standard method of diagnosis. It's been replaced with the standard of CT, with CT angio, but it has the benefit of being therapeutic as well as being, or at least offering the opportunity for therapeutic intervention during your diagnostic evaluation, because you can perform angioplasty with or without stenting and provide treatment for intra-arterial vasodilatation. The treatment medically initially is IV fluids. Recognizing that these are thrombotic events means that it's important to start these patients on heparin. And there's been a tidal shift towards emphasizing endovascular repair. So, certainly worthwhile to discuss with the vascular surgeon, with the interventional radiologist, to determine if that would be the approach, as well as starting antibiotics. The surgical approach is really for patients where you feel that there's a significant prolonged injury that's led to dead bowel that requires resection. So surgical consult, vascular, and IR are your considerations for those patients. Medically starting them off with IV heparin and IV fluids and antibiotics. So are there any questions about mesenteric ischemia treatment and workup?
Does the heparin work with atherosclerotic patients?
Yeah, so the chronic ischemic patients, they may only be receiving IV fluids and heparin and may not have any immediate endovascular approach to them. And so that may be at least not an emergent endovascular approach, I should say. I think most of these patients are going to have some form of there'll certainly be a consideration of an endovascular procedure, whether or not that'll be just angiography versus otherwise. The patient that presents that looks really ill, who's peritoneal and CT scans showing signs of bowel wall thickening with this and has high lactic, that's a patient who's really surgical, right? That's a patient who you can see there's already effective ischemic injury to the bowel, and you suspect that there's areas of necrotic bowel that need resection. And unfortunately there's no combination of imaging tests or laboratory tests that give you 100% confidence in what the intraoperative appearance is compared to what that would suggest. But clinically, there's room for that clinical interpretation of saying, okay, I think that this is more likely occurring, and therefore I think surgery should be emphasized in consultation with your surgeon and getting them down to see those patients. All right, so question 13 referred to that article as well as question 14. So the next article is looking at managing migraines. And so this article is by Dr. Friedman and looks at, what are the best first-line parenteral treatments for migraine. And obviously with the opiate crisis and everything else that we've been through in our training, there's a de-emphasis of using opiates for that. And it's for a number of other good reasons besides just the opiate crisis. Is the issue that extensive use of opiates is associated with rebound headaches and a medication overuse syndrome with those patients where they become somewhat dependent because of the overuse of medication for them. So the first-line parenteral treatments are using sumatriptan subcutaneously, using IV Reglan, IV Compazine, and Toradol. And listed here are the cautions and contraindications. Again, Reglan and Compazine are both associated with akathisia. Giving diphenhydramine at the same time of giving Compazine decreases the risk of akathisia. So, that's something that I've often not done that. I've often just given them that, and if they develop akathisia, and the nurse always lets me know because that patient's terribly uncomfortable, and right. So I think in the future I'm going to find myself, if I'm going to go to somebody who says I don't do well with whatever, or I'm not going to give them Reglan for some other reason, and I'm giving Compazine, I'm just going to combine Compazine and Benadryl in the future. It would just be easier. But it says it's not indicated to do that with Reglan. And then here it's listed as 30 milligrams or 60 milligrams 30 milligrams IV or 60 milligrams IM for this. I don't want to disagree with the author, but there's a lot of data that suggests that there's a ceiling effect with Toradol, and that ceiling effect for pain relief usually occurs at the 10 milligram level, but it's easier because it's packaged in 60 milligrams. It's easier to pull, it's packaged at 30 milligrams. It's easier to pull half of that and just give 15. But here the recommendation is 30. And so if you get a patient who doesn't respond to 15, then I guess it's fine to give them the next 15, and then you're within at least this particular guideline. The use of sumatriptan, the author here makes some arguments as to why it should still be considered use as a first-line treatment. I often consider it to be an abortive agent to be given in the first couple of seconds, and if it's not in that time, sometimes I kind of feel like the horse is out of the barn on that, and I haven't seen a lot of patients turn around quickly with sumatriptan, but the author cites some papers that show that that patients can still benefit from it, so it's worthwhile to give. The side effects of sumatriptan is flushing, dizziness, palpitations, drowsiness, and sometimes there's injection site reactions. It's contraindicated in patients who have cardiovascular risk factors, and it should be used cautiously in anybody that's received triptans within the past 24 hours. So if they've already taken Maxalt at home and they're coming in with this, then I would avoid sumatriptan and just go straight to Reglan. And often Reglan's recommended as a first-line therapy for pregnancy and for children and so on and so forth. So that's usually my go-to with this. And it's because it has a favorable pregnancy rating, it's really considered the primary parental therapy for them. Recommendations here are to alter the way that Reglan's delivered, though, to put it in an IV drip lasting 15 minutes. And they also give recommendations here of doing the same thing with Compazine in a drip over 15 minutes with either 25 of Benadryl or 2.5 of droperidol. There's a lot of hospitals, and I think the FDA still has a black box warning on IV droperidol, so I don't know that we could do that here. Anyway, so either way, it's not a quick push. And Michelle, you give this more often. Well, you give this and I don't. So help me understand. When you're giving 10 of Reglan, is it something that you're usually dripping, or is it something that you're?
No, it's over like 2 minutes.
So it's a 2-minute push generally. Yeah. So yeah, so this is recommending basically IV piggybacking this and giving it that way. Which probably, I don't know, is that burdensome for you to do it that way, or?
Well, we'd order it from pharmacy, so the treatment would be delayed.
Okay, so there's a timing, there's a time cost on it.
Reglan, but they would have to mix it up there because we don't mix IV drips in the ER here at this hospital.
Okay, got it. So you can't just get a 250 cc bag, push it in, and just be like, got it. Okay.
we
Understood.
can.
Understood. No, got it.
So what we do is usually we just have it, if it's ordered that way, then we order it and they have to send it down March.
Okay. So again, the recommendation here is give IV Reglan over 15 minutes in a drip. If that doesn't work, give a second dose of Reglan now with Toradol. If that doesn't work, give a third dose, and now consider adding ergotamine, lasting at least 15 minutes as well. And then if that doesn't work, then consider bilateral occipital nerve blocks. And if that doesn't work, oral opiate combination, such as Percocet, for those patients. And so that's kind of the algorithm and approach that they recommend. I've had a number of patients do really well if they come in with an obvious trigger point sensitivity. So if you're over the trapezius and as you're pressing over the trigger point there, if that elicits the pain and discomfort right away, and they're particularly describing to you that they've been trying a bunch of different medications and they have been working, sometimes they're just gone straight to doing a trigger point block and just using either 0.25 or 0.5 Marcaine, with usually about 2 cc's to 4 cc's of lidocaine, so there's a more immediate effect of anesthesia as they're feeling it. That's often has helped right away. And doing that in the occiput, kind of not at the lower occiput, but at the higher portion of the occiput, kind of where the trapezius is inserting, is also a good place to do that. You don't want to go too low because you don't want to catch any of the cervical nerves as they're coming out. It's frowned upon. But I've even had at other places colleagues that I've treated with that where they've just been like, I can't get rid of this, and you give them an injection, they're able to get through their shift and do fine. So the blocks really work well. John Howell is an excellent person to ask about that because he's really an expert in them. So, all right. So question 15 is associated with that article, as is question 16. So the next article looks at pediatric non-traumatic hip pathology by Dr. Neville and Dr. Zuckerbrunn. And this looks at the various different pathologies that occur in kids that make them limp, right, from hip disease. The first is late calf Perthes disease, which is really just avascular necrosis of the epiphysis of the femur. So here's your physial line going through here. Here's your epiphysis, and avascular necrosis can occur in kids, and basically it's somewhat of a self-limited disease for the most part. The avascular necrosis, this basically shows a timeline of what occurs, and so you first start off with femoral head fragmentation, then you have some evidence of osteoblast activity where you're getting increasing amount of exostosis occurring around the bone, and then in panels C, that that's occurring even more so. You'll see some what looks like maybe even osteophytes that are forming, and then over D and E you can see that you get a femoral head flattening and fragmentation and over time, and then that's just the shape that it's going to be. In these patients, it's self-limited. The cause of the avascular necrosis is not well understood, so it's described as an idiopathic avascular necrosis of the femoral epiphysis. And after the initial devascularization of the blood supply to the femoral head restores normally in about 1 to 2 years. So these are generally patients that are going to remain non-weight bearing and have an orthopedic follow-up, but there's generally no immediate intervention for them. For patients who have osteoarticular infection, so this is patients with septic arthritis or osteomyelitis, and inflammation of the joint space is due to infection. It's an emergency, and delayed diagnosis and treatment leads to irreversible joint damage. So the inflammation of the bone due to infection can be an isolated problem or can coexist with septic arthritis. So osteo can be by itself or can be associated with septic arthritis. There's Coker criteria to apply here, and it's worthwhile to know. So that criteria is fever, refusal to bear weight, a SED rate greater than 40 millimeters per hour, a peripheral white count greater than 12,000. And if you have all 4 of those features, there's a 99.6 probability that you have a septic arthritis or osteomyelitis. And so I don't know if I learned it at any point, but I definitely learned it in this article. So it was interesting to see that what a high probability was associated with those, all 4 of those being present. The probability decreases if there's only 3 of them present or 2 of them present, and so on and so forth. There are a number of studies that have repeated analysis of applying Coker criteria, and they haven't found the same level of sensitivities as the 99% range. And so in those other articles I've kind of listed here, that what they've done is to augment that is they've used the Coker criteria plus adding a CRP. And if the CRP value is greater than 20 milligrams per liter, then there's a number of articles that support that that gives you 98% sensitivity for picking up septic arthritis and osteo. An important point to mention kind of down here, it's somewhat obscured on the slide, apologize, but CRPs are displayed differently in different hospitals. I don't know why, it's a thing. And so they're either displayed as milligrams per liter or milligrams per deciliter. And so this is where the units matter. And so if it's more than 2 milligrams per deciliter, then, and the Coker criteria is present, then 98% chance that that's osteo. If the CRP is less than 2 milligrams per deciliter, or less than 20 milligrams per liter, and they're able to bear weight, so just those 2 issues, they can bear weight and their CRP is under that 20/2, then there's less than a 1% chance that it's osteo. So I think it's worthwhile to at least know this, and again, don't treat it like dogma, but give it consideration for your informing you about your pretest probability, or even in this case, you've already checked a CRP, so technically not a pretest, but you're at a point now where your post-test assessment is going to be informed by this. Now, the diagnosis is not made based on the Coker criteria, despite its association with high probability. The diagnosis is based on fluid culture. And the fluid cultures, interestingly, just on their own, are only 50% sensitive, meaning you identify the organism only 50% of the time from the actual sample intraoperatively. But that increases to an additional 40%, so you're at approaching 90% identification of the bacterial pathogen when you're using PCR tests. So there are a number of different laboratory firms that are out there now that are producing various different PCR tests that are like a shotgun test of a number of different organisms to look at from a PCR standpoint. They're called like BioFire, and I think there's a number of other ones, other names for them, trade names. But those get you closer to 90% when you're doing that. If you already have a suspicion of different organisms that you think this is, then sending specific PCR for those organisms is appropriate, depending upon what that patient's exposures are. The blood cultures are positive anywhere from 15 to 30% of the time, and it probably has a lot more to do with the vascularization of the area that's involved. So if you have somebody who's got peripheral osteo of the foot and has poor vascularization to that area, you may not expect the blood cultures to be as likely to be positive if it's a small area that this has begun with. But certainly worthwhile, blood culture should be sent on all patients where osteo is concerned. And then there's a little bit of concern, going back here, as to whether or not to start antibiotics before obtaining cultures. If they're surrounding cellulitic infection and skin breakdown, then it's certainly worthwhile to start antibiotics, but if not, and also obtaining wound cultures in those settings. But just recognizing, again, the wound cultures by themselves may only approach a 50% level of sensitivity. And so I had a patient the other day that had osteo based on the MRI, and it was better to not initiate antibiotics and wait for the operative care to be able to get an appropriate sample and then go from there.
Hey, Chris?
Yeah.
So the recommendation is to get both the CRP and the sed rate along with the CBC.
Yeah, I think this article didn't get into recommendations as strongly as the other articles we've covered so far, but it was an explanation of what the Coker criteria was. I've learned it that way, that if you have patients with osteo, that you want to get an initial CRP on those patients anyway, and the rationale for that is that the CRP levels are used in follow-up for efficacy. So the trending down of CRP over time is generally what's being followed in the offices. So it's worthwhile to get a starting one when they come to the ER anyway. And then the SED rate is part of that Coker criteria. So I usually in our settings, I usually use the cellulitis order set and just click off SED rate and CRP without thinking twice about it.
Thanks.
Yeah. The next issue is the most common issue for kids limping, right? Which is young kids who've had a recent viral infection, whether it's an upper respiratory infection or gastrointestinal infection that come in with a limp, and are really just experiencing transient synovitis. That's just a self-limited inflammation. That's treated with an NSAID, and that's it, right? So that's a kid who comes in limping, and you're like, hey, did you just, do you just have a cold recently, or did you have a tummy ache, or you have some vomiting, diarrhea, and days later they've got this hip pain. Usually you don't need any imaging to evaluate that kid. The key features for all of these hip patients is that one of the things that makes it tricky or a little difficult is that the position of comfort for when a hip is either inflamed or injured is externally rotated and flexed, which automatically gives you an impression that it's shortened just because they're holding it up and they're flexing it, right? So that initial presentation just always kind of puts you at concern about that. The features that are concerning is a kid that's got a fever like that, a kid who refuses to bear weight. And I always learned on young kids, the best way to examine them for this was to put them on their belly on the bed and see if they'll get up to crawl. And if they won't crawl with that knee, then they're telling you that they're not going to bear weight on their hip, because you kind of really have to bear weight on the hip in order to crawl. And so the history and examinations are important here. You're looking for a kid who's got acute onset of growing or thigh pain with a limp. They may be unwilling to bear weight too, but they're holding their hip inflection, abduction, external rotation. There's limited range of motion on exam initially. Some authors are describing this as a non-traumatic pathology of unknown origin. When they looked at a series of this, they looked at 417 kids who presented with acute irritable hip, and out of the 417, 383 of them had transient synovitis. So it gives you an idea of the epidemiology that you're more, that's more likely to be the pretest explanation for this than not. But the red flags of fever, not bearing weight, having, an increased SED rate, peripheral white count, those are all signs that point away from transient synovitis, right? The transient synovitis kid is usually well-appearing, non-toxic, afebrile. They may have a low-grade temperature, but that's about it. And only 1% of them had temperatures of over 38.5 Celsius. So the majority of these kids aren't that way. So if I get a kid with a high fever, I'm not really thinking transient synovitis. There's still a 1% chance that it is, but that's not going to be my go-to. I'm not going to take that kid and go like, oh, this must be transient synovitis. Like, I'm going to be thinking this is more likely to be septic arthritis, and I'm going to do that, look at that Coker criteria and all that other stuff. The diagnosis is basically clinically here. Most of these kids don't require arthrocentesis. Diagnosed in a kid who, again, kind of fits the right age group too, that they're between 3 and 8 years of age. There's no trauma, there's no high fever, there's no other concerning examination findings. And during the evaluative period, they're improving with NSAID therapy, right? So again, kid shows up, he's got a URI, painful hip, here's some Motrin, let's see how you do. And if we need to do a workup and look at this, and you're able to bear weight and your CRP is low, then really unlikely that it's septic and they're improving, great. Transient synovitis later. Management, again, is just follow up in 5 to 7 days, continued NSAIDs, and just kind of review the risk factors with the parents, saying, listen, you need to come back if there's high fever, if there's progressive pain, or continued inability to bear weight, or if they appear toxic at any point. Here's a diagram looking at SCFE, right? So here's the physis. SCFE is just a slipped capital femoral epiphysis. So, some people describe this in a number of different ways, like ice cream falling off the cone, all that sort of business. The management with a SCFE is that they're non-weight bearing and they have outpatient orthopedic follow-up. In the outpatient setting, they'll set them up to stabilize the epiphysis. Usually it's a nail that comes across for that, but there are a number of different ways besides screw fixation to use for that. But screw fixation is the typical way of doing it. Here's the way of measuring and finding subtle SCFEs, right? This is not a subtle SCFE that we're looking at here. That's a pretty obvious slipped capital epiphysis, but you're basically drawing Klein lines, and the line here on the left hip is going to intersect the femoral head, right? So as you're going along basically it's a line along the femoral neck that's being drawn through the acetabulum, and there should be a femoral epiphysis laterally to that line. And here we're on the femoral neck, drawing that through the acetabulum, and there is no femoral epiphysis laterally. The subtleties are that there can be a difference of 2 millimeters between the distances on one side versus the other. So that's the earliest indicator, is to see that there's a 2 millimeter difference between what's present laterally versus the other side. And if you see that, and the patient's having difficulty bearing weight or refusing to bear weight, or having this is an acute onset and overweight kid, then there's your criteria for consideration of SCFE in that group. Again, you're going to make them non-weight bearing and have them follow up with orthopedics. Any concern about SCFEs? Cool. So question 17, question 18, and question 19 all refer to that article. The next article looks at current controversies in thrombolytic use in acute pulmonary embolism. Dr. Long and Dr. Koifman authored this article. This was an article that really focused a lot on promoting the use of fibrinolytics in patients, and it balanced that discussion with what the risks and benefits were. In patients with massive pulmonary embolism, these are patients who are either have pulselessness, persistent bradycardia with heart rates of 40 or below 40, and have signs of shock or sustained hypotension. I don't think there's a lot of controversy about giving fibrinolytics to those patients. There's 3 different types of fibrinolytics that you can give them. You can give them TPA, you can give them tenecteplase, and you can give them streptokinase. I don't know anybody that's giving streptokinase anymore. It's fallen out of favor for the most part, but tenecteplase and TPA are used. I personally prefer tenecteplase over TPA in those settings, because the tenecteplase can be pushed and delivered within 3 minutes, whereas the TPA is an infusion over a period of time, and if somebody's hemodynamically unstable, I'm more comfortable giving something that doesn't require enzymatic activation, and TPA does. So I always think of tenecteplase as like more like a bomb. Like once you set it off, it's off, and TPA is something that you deliver, and then it's got a long fuse. So those are kind of the differences to them. And so in the more acute setting, I like it, but certainly when it gets to the point of interventional radiology, I think that the treatment usually is a thrombolysis, a catheter-associated thrombolysis is usually with TPA. I don't think they use tenecteplase, or not very often if they do. Now, so again, I don't think there's any controversy with massive. Now, in the submassive group, there's some controversy. These are patients who may have normal or near normal blood pressures with evidence of cardiopulmonary stress, even including echo showing right ventricular dysfunction or having elevated troponins indicating myocardial necrosis. When there's RV dilatation on the echocardiogram, and that's usually a ratio where the RV diameter is divided by the LV diameter, and if that's more than 0.9, then so they don't have to be equivalent. It doesn't have to be 1-to-1, but if it's greater than 90%, then that's how RV dilatation is defined. If there's systolic dysfunction on the echocardiogram, one way of looking at it is what's called a McConnell sign. The McConnell sign is sometimes described, it's seen on a 4-chamber view, and it's sometimes described as a trampoline sign. The reason that is that when you look at the apex on the right ventricle, you see it contracting and bowing down and out like somebody was jumping on the right ventricle as if it was a trampoline coming up and down, and then the rest of the free wall of the right ventricle is not moving. And then those patients who have an elevated BNP or elevated pro-BNP and EKG changes showing right heart strain with right bundle branch block or anterior ST elevation and anteroseptal T-wave inversions. Those are signs of dysfunction, and obviously myocardial necrosis with an elevated trope. The authors give recommendations to consider fibrinolytics in those patients to decrease the sequelae of pulmonary hypertension. Here are a number of different guidelines from different groups. So the American Heart Association, American College of Chest Physicians, European Heart Association, American College of Emergency Physicians all have different recommendations here. So everybody's pretty much in agreement on massive PE. Give a fibrinolytic when it's reasonable for the patient to receive that and acceptable risk, and you've excluded the likelihood of them having an aortic dissection, right? And that's American Heart, the College of Chest Physicians says, BP is less than 90 and there's low to moderate risk of bleeding. Thrombolytic therapy is recommended. And those who have an acute PE who decompensate after starting anticoagulation, it's also recommended to start it with those patients. European guidelines it's a first-line treatment in patients with high-risk PE presenting with cardiogenic shock. And the ACEP guidelines are to administer it in hemodynamically unstable patients with confirmed PE, who the benefits of treatment outweigh the risks of life-threatening bleeding complications, and to consider it in patients who are unstable with a high clinical suspicion for whom the diagnosed PE can't be confirmed in a timely manner. Now, for submassive PE, this is where there's a little bit more differences, right? So fibrinolytic therapy is recommended by the American Heart for patients with PE or judged to have clinical evidence of adverse prognosis with new hemodynamic instability, worsening respiratory insufficiency, severe RV dysfunction. The chest physicians group recommends it in the majority of patients with acute PE and no hypotension and no thrombolytics should be given. So they're basically saying, listen, the epidemiology that they're referring to is interesting to me. In this article, they found that the majority of patients had massive PE. I clinically haven't seen that in the ED, but the inpatient world may be quite different. So perhaps PEs that are diagnosed on an inpatient basis are more likely to be massive. Is that something you see, Ian?
I can't say that necessarily, no. I would tend to think the ones coming from outside are the more massive ones. Every time I'm giving, the majority of times I'm thrombolizing these people, they're coming from outside.
Okay. So yeah, it was just one of the slight skew to this article was just that the higher proportion of massive versus submassive, because I usually experienced it the other way. And then, so again, according to the American College of Chest Physicians, if there's no hypotension, no thrombolytic. And then European Heart routine use of thrombolysis in non-high-risk patients isn't recommended. Can be considered in selected patients with intermediate risk PE after consideration of other risks of bleeding. And that's really the issue here, is that there is an increased risk of bleeding, and intracranial hemorrhage is a potential risk in these groups. So the administration of this is not taken lightly. The ACEP guidelines is that there's insufficient evidence to support recommending thrombolytics in any subgroup if they're hemodynamically stable. And then they recognize that there are articles that demonstrate faster improvements in right ventricular function and pulmonary perfusion, but those haven't necessarily been translated to improvements in mortality. So questions 20 and, is that it? Yeah. So just question 20 refers to that article. Any questions about that? Okay, cool.
Yeah.
Next article.
Chris,
Sorry?
question. Any data on whether intraarterial TPA versus systemic TPA makes a difference?
So there is data that's been studied about that. I don't think that there's a robust data set to suggest that you should withhold peripheral fibrinolytic for catheter lysis. But there's a lot of data that's also shown a non-effect of peripheral fibrinolysis, particularly patients with massive PEs. You know, I've had the unfortunate experience of going to an autopsy on a young patient that had died from a PE. And during the autopsy, looking at the amount of burden of pulmonary embolism, and also almost like a sedimentation of the clot itself. Like there was organized areas of clot that were different from one portion or another. So this clot, these clots can occur in a number of different ways, right? You can have the clot be one where there is a large DVT that mobilizes and gets thrown, and that can be a large clot burden too. And then other instances where you have a nidus, right? And that nidus continues to form. And the formation of the ones I think that start off as a nidus and then propagate tend to be the ones I think that are more organized with their structure and have different levels of sedimentation to them. And it's really difficult to imagine that a circulating fibrinolytic is going to have much of an effect there. And so I think the catheter associated is probably better in that circumstance. But there's also one that I know from our standpoint, we don't give much thought to, which is consulting with cardiothoracic to just do an embolectomy. And that's probably a better route in patients that have a large DVT that's mobilized and has suddenly kind of gone forward. And I did have a patient once where I was echoing them and I was looking at their IVC, and you could see this long, huge clot that was in their IVC threatening. And I remember calling the intensivist, and intensivist coming down. We were looking at this, and we were, already giving TPA and everything else like that. But it was like a ticking time bomb, and then she arrested. And then I looked again, right, and the clot's missing. So it was clear where it went. But like looking back at that, if I had to do that over again and I could try to optimize it, I think I would have simultaneously called IR and called the chest surgeon, so that way there could be an approach and decision making about what would be the optimal strategy there. And I don't know that it would make a difference. Like this is one of those things. Like it's such a lethal problem when it really is, right? And then you have the flip side of this, where most of the time these are subsegmentals. We're missing half of them. We don't really care. So I think it's just one of the interesting controversies to PEs.
I was just looking it up. It looks like there is a trial that's ongoing comparing the two. So maybe we'll get an answer.
Yeah, no. So there's definitely trials. I don't know that there's a robust amount of data that's been published across centers that indicate that there's agreement. That's all. Okay. Next article is on new onset seizures in adults and adolescents, and this is a review. Basically looking at, you get a new onset seizure, and again, this isn't applying to kids, so this is not the febrile seizure workup. This is adults and adolescents. And so the first thing is, the recommendations are to consider brain imaging patients with a first seizure. That the majority of these should have neuroimaging, and suggest that about 10% of them are going to have abnormalities seen on CT. That MRI has a slightly improved detection rate of abnormalities compared, and that the abnormalities seen on MRI are up to 30%. And that emergency neuroimaging is recommended. Now, whether that's CT or MRI, they don't really make a strong point for one versus the other. And I think in general, we're all fine of just starting off with a straight CT for those patients. And certainly if they have new neurologic deficits, if they're persistent altered mental status, if there's recent trauma and prolonged headache, there's some recommendation in those patients that not only should they be followed with brain imaging of initial CT, but even an MRI. And even if the MRI isn't diagnostic of anything, that if there's a persistent symptoms, so if there's a persistent neurologic deficit, mental status issues or whatever, to consider a MRI epilepsy protocol. And that was something I was unaware of was a thing. So those are considerations for somebody who's having that. Now, that's not an emphasis here, because the bigger emphasis on somebody who's having prolonged neurologic dysfunction is really to emphasize getting an EEG on those patients, because they may be having subclinical status epilepticus. And the only way you're going to know that is if you're doing an EEG on them. So imaging isn't the way of working out the patient who shows up with a persistent weakness on one side of their body or a waxing and waning level of consciousness that's prolonged. EEG should be done for those patients, and that's a really clear recommendation by the authors here. I just thought from a learning standpoint, it's interesting to know that there's an MRI epilepsy protocol, and that patients with a prolongation of symptoms should have that further imaging modality. Chemistry panels are worthwhile just to check to see if there's hyperglycemia, hyponatremia, if they're uremic or drug intoxication. So there's some benefit to that. Lumbar puncture is considered only in cases really where you really think the patient's meningitic or encephalitic, or they have a subarachnoid. So the sudden onset, and you think, and they're having a severe headache, and there was epileptic tonic-clonic seizure associated with it, then if everything else of the workup's negative and there's no other obvious trigger, then considering LP is reasonable. Obviously, in the febrile patient with seizures who's got a rash and stuff like that, that's reasonable. And then prolactin levels are here in the lower right-hand corner because they're de-emphasized. It's important to note that you can't really use a prolactin level to differentiate between pseudoseizure and real seizure. In general, prolactin levels are normal in psychogenic seizures, and they may be elevated in certain forms of epileptic seizures, but it's really based on the timing. And the key thing is, like, if you're going to play that game, you need to know what their pre-seizure prolactin level was, at least 6 hours before their seizure, and then measure it 6 hours afterwards, and then that's when you're studying the prolactin levels and doing that. It's not feasible in our setting, so I don't really think it's even worth really giving much consideration to. Just it's something that's out there, and so I figured I would just address it since it was covered in the article. And then again, EEGs, I'm going to emphasize, most new onset patients who don't return to baseline neurologic function within 30 to 60 minutes, and they have a waxing and waning level of consciousness or have focal dysfunction that's unexplained. So if their imaging is negative and they're still having a focal dysfunction, then the EEG is important to get. It's not important necessarily to get in every patient a new onset seizure, so I don't want to overemphasize this. They need to get an EEG at some point in their post-seizure period, but that can be up to a week later. These leave remnants of ripples of waves in the brain. So you can kind of think of like a big, huge stone being dropped in the water, and the ripples continue for up to a week or so later, so they can still be measured on an outpatient basis and don't necessarily need inpatient evaluation unless they have persistent findings. So the algorithm approach here is patient new onset seizure. Is there event description and witness reported suggestive of seizure? If no, then evaluate them for other things, migraine, TIA, syncope, so on and so forth. If yes, this seems like this is seizure, then obtain history, perform physical examination. Is there evidence of fever, focal deficit, or mental status change? If so, more urgent evaluation, lab testing, urgent CT or MRI, urgent EEG, or in management with inpatient. If, again, there's no evidence of fever, focal deficit, mental status changes that are persistent, but there's evidence of provoking factors such as sleep deprivation, alcohol, medications, or drugs, then workup is lab, brain CT, outpatient EEG. Management is lifestyle modifications and likely deferring antiepileptics in those patients when there's a provoking factor. If there's no provoking factors, and this is an unprovoked seizure, recommendations are for EEG and epilepsy protocol MRIs. And if those test results are abnormal and consistent with the etiology of epilepsy, then choosing a first-line antiepileptic agent is recommended. If not, and the tests aren't abnormal after EEG or MRI, and it's a first unprovoked seizure, then defer antiepileptics. What was interesting in this article is I didn't realize that there are states that don't have mandatory reporting for DMV for this. So the authors are recommending that every single one of these patients should be advised about risks of driving. So if you're in a state that doesn't require that, then okay. The other aspect that was an interesting statistic was that patients with epilepsy and who've had seizures like this, the majority of them may have just a first onset seizure and nothing else again. But the likelihood of sudden death and drownings are 20 times higher than the rest of the population. So it's 20-fold increased risk of mortality with that. And so obviously avoiding climbing on high ladders and roofing and, hiking from high places, and then avoiding standing bodies of water, including bathtubs. I had a really horrible experience 6 years ago taking care of a 19-year-old that was taking a shower, and she had a shower that was like a walk-down shower. And so the drain had clogged, and so water had accumulated. She seized in the shower, and she drowned. And it was just, it was a horrific episode to take, or at least to participate in. So hopefully that scary story just motivates you to tell patients to avoid the bathtub. New onset epilepsy, again, individual with new onset epilepsy, one seizure, an abnormal EEG or MRI, or two seizures, then you kind of follow this algorithm. If it's a focal epilepsy, begin anti-epileptic medication, narrow spectrum medications such as Dilantin, carbamazepine, oxcarbazepine. Probably oxcarbazepine is becoming a more frequent use drug in that group because it has less side effects, or going with broad spectrum medications such as valproic acid, topiramate, Keppra. Obviously, I think locally our practice is we're usually starting patients on Keppra for that. And patients and that's for focal epilepsy, right? And patient who's got a generalized tonic-clonic epilepsy or unknown type, then you just begin broad spectrum, which is usually starting them on Keppra or valproic acid or topiramate. Keppra has the issue of worsening depression, so if you have somebody who has a known history of depression, then you're better off starting them off on lamotrigine, or obviously in consultation with neurologists considering whether or not to give them topiramate or valproic acid. Titrating them to a therapeutic dose. If the patient's still having seizures, right, so that patient's coming back to you, second seizure, and they're on their medicine, they're either titrating that medicine or you're adding a secondary medication for dual therapy. And if the seizures persist, then revisiting the diagnosis for seizures, that persists for more than a year, and considering epilepsy monitoring and unit admission for the patients that are having persistent breakthrough seizures of high frequency. So question 21 refers to that article. The next article is on critical issues in the evaluation of adult patients with suspected transit ischemic attack in the emergency department. This is a policy review by ACEP. And so the ACEP experts pose a question and then give an answer for the question based on the levels of recommendation. There's only going to be 4 questions here. Their initial question is, in adult patients with suspected TIA, are there clinical decision rules that can identify patients at very low short-term risk for stroke who can be safely discharged from the ED? And level A recommendations are the highest recommendations, but they don't have any for that. Their level B recommendations are that in adult patients with suspected TIA, don't rely on current existing risk stratification instruments such as age, blood pressure, clinical features, duration of TIA, and presence of diabetes score to identify TA patients who can be safely discharged from the ED. There was a good study that was done at a Kaiser up in Oakland that looked at applying the ABCD criteria to ER patients, and there's a difference. ABCD criteria works really well for the outpatient setting, and there's something special about our patients that come to us where their TIAs have a higher pre-test risk than they do in an office setting. So, you shouldn't use the ABCD criteria to inform about why you're discharging somebody if you're doing that. And if anything, you're using that criteria to just inform the inpatient physicians about what the risks are for somebody who has, who fits a higher risk category. And then level C, there were no other recommendations that were just based on opinion. So level B is based on some evidence, not a robust amount of evidence, that you just can't rely on an instrument to say who can be safely discharged. In patients who have suspected TIA, wet imaging can be safely delayed from the initial ED workup. Again, there's no level A recommendations, B recommendations, but the overall group thinking on this is that the safety of delaying neuroimaging from the initial ED workup is unknown. If a non-contrast brain MRI is not readily available, it's reasonable for physicians to obtain non-contrast head CT as part of the initial TIA workup to identify TIA mimics such as intracranial hemorrhage or mass lesion. Non-contrast head CT should not be used to identify patients at short-term risk for stroke. And then when feasible, physicians should obtain MRI with a diffusion-weighted image to identify patients at high short-term risk for stroke. Here we order that as a short sequence brain MRI. You have to just type it in the comment section for them to do that. It only takes 10 minutes to do it, so you can get an MRI done quickly if that's all they're doing. Sometimes there's confusion when you put the order in, so if they do a full MRI, it's going to take 30 minutes for them to do it, but you can just call ahead and talk to them about it. When feasible, physicians should obtain cervical vascular imaging, such as carotid ultrasonography or CT angio or MRA, to identify patients who are at high short-term risk of stroke. Question 3 that they put in is, in adult patients with suspected TIA, is carotid ultrasonography as accurate as next CTA or MRA in identifying stenosis? Again, there's no level A or B recommendation, so this is a group think of experts that in adult patients with suspected TIA, carotid ultrasound may be used to exclude severe carotid stenosis because its accuracy is similar to MRA and CTA. And then the 4th question they ask is, in adult patients with a suspected TIA, can a rapid ED-based diagnostic protocol safely identify patients at short-term risk of stroke? So here, there's no level A recommendation. There is evidence. So level B recommendations are that in adult patients with suspected TIA, without high-risk conditions, and that's a key feature. So no high-risk conditions, which means they can't have an abnormal head CT. You can't have suspicion of embolic stroke. So no AFib, no patients with cardiomyopathy, no valvulopathy patients, and you're not doing this to patients that you know have carotid stenosis or have had a previous large stroke or crescendo TIA. So in everybody but them, a rapid ED-based diagnostic protocol can be used to evaluate patients at short-term risk of stroke. So Again, the algorithm here is ED evaluation, history physical, ECG, basic laboratory assessment, non-contrast head CT. If there's exclusions to the rapid ED protocol, that was what we just mentioned of having AFib, concern that it's embolic, they've had a prior large stroke in the past. If they're excluded, then admit those patients to hospital for the appropriate TAA stroke workup. If they don't meet those criteria, then a rapid ED-based protocol can be applied with serial clinical examinations, telemetry monitoring. You can consider further imaging with diffusion weight, MRI, echo if necessary, if you're hearing murmurs, and then neurology and cardiology consultation as needed, and initiate them on antiplatelet therapy. The admission criteria is for crescendo neurologic symptoms on repeat examination, patients with AFib or other dysrhythmias on telemetry, patients with cerebrovascular disease on imaging, acute CVA on imaging, and social or medical factors that make discharge or follow-up unsafe. So the homeless patient who's not following up with anybody, who's having TIA symptoms, probably not the right person to go like, you're fine. It's probably better just to admit them and have them get worked up. So questions 22 and 23 refer to that, and that's it. That covers all the articles associated with the 2019 LLSA. We'll have this. I'll have the slides available, and we'll send out the video of this too for everyone else to see and watch at their own time if they want to use this to prep for the LLSA. And basically, you can pause it at any time and just finish the questions as you're going along, and you should be able to finish the test within 2.5 hours, if not sooner. Cool.
Thanks, Christian. That was awesome.
All right, thanks, guys.
And then,
Thank you.
And then tomorrow we're doing this with a live webinar, so if you want to watch that, it's going to be the same thing with the questions and the answers, but or at least we'll discuss the answers. Since ABEM never allows me to actually like circle the answer, even anyway.
can I ask you one question about the last article? Is it recommending that you do an MRI before a patient is discharged if they didn't have any exclusionary factors?
Yeah, so it's not recommending that you have to do an MRI. So go to that slide for just if I go back to that slide here for a second. The algorithm that they're recommending is a consideration of that. So again, these are going to be low risk patients, and it says imaging here, MRI or vascular imaging. So this is really like whether or not you're going to CT angio those patients or consider getting an MRI or MRA of them. It's not specific on what you have to do. I think it's dependent on the for me, I kind of use some of the other decision support instruments out there to just inform me about what my own risks are that I'm at, and then I'm kind of considering it in the terms of like, is this somebody who's presented with a long duration of symptoms? If they have symptoms that were more than that were 30 minutes or longer, those are patients I'm more concerned about having an undiagnosed vascular abnormality on a non-con CT. So then I'm certainly considering CT angio or diffusion weight MRI on those patients. I've gone back and forth with this with our neurologists, and there's heterogeneity in their practice. So there's some that are like, just if you can get a quick short sequence MRI, do it. And there are others that are like, no, that's fine. We can follow up with this patient later. The risk factors were pretty low. This patient had really short symptoms, and they don't have other risk factors such as dysrhythmias and other things like that. Then it's not prescribed that they have to do additional imaging.
All right, thanks, Chris.
Yeah, sure, absolutely. Thank you.
All right, see you.
See you.